Occupational English Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with the information you hear. Now look at the notes for Extract 1.
Extract 1. Questions from 1 to 12.
You hear a physician talking to a patient called Mrs. Emmeline Pethick.
For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, good morning, doctor.
Good morning. Tell me what's your problem.
Well, I have a Codman-Haycom shunt set at 90 millimeters H2O. Recently, I'm getting acute onset of headaches, and it's worsening day by day. I am unable to sleep. The pain is constant and is worse with coughing, straining, and sneezing, as well as standing up.
What's your age?
40, doctor.
Did you take any medicines then?
Yeah, I've tried taking Imitrex as well as Motrin 800 milligrams twice a day, but it has not provided much relief. Although the pain is generalized, it is quite intense in the frontal region of head. I get a feeling of ringing in the ears. I have been experiencing intermittent blurry vision and dimming lights as well.
Do you drink or smoke?
No, doctor.
Well, I've reviewed your diagnosis reports. Your physical exam reports show blood pressure at 153/86, pulse at 63, and respiratory rate 16. Cranial nerves intact for extraocular movements. The shut site is clean, dry, and intact. You have a small 3 mm to 4 mm round scab that was noted farther down from her shunt reservoir. It looks like there's a little bit of dry blood there. The worsening headaches are secondary to shunt adjustment back after an MRI. You have pseudotumor cerebri without papilledema and migraine headaches. Well, your shunt back program to 90 mm H2O last time was after confirmation of an X-ray. However, it seems the picture of the X-ray last time was not most desirable. Therefore, I'm planning the shunt back to 90 mm H2O again tomorrow. So, you have to have another skull X-ray to confirm the shunt back program to 90 mm H2O. Extract 2, questions 13 to 24.
You hear a doctor talking to a patient called Alejandro.
For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, doctor.
Good morning, Mr. Alejandro. Can you tell me about your problem?
Doctor, over the past week, I've been getting an increased shortness of breath. I have also developed some abdominal pain. However, I was continuing my regular activities until the other day when I passed out at home. My wife called paramedics and I was brought to the emergency ward.
Oh, I see. Hmm, what's your age?
35, doctor.
Your diagnosis report shows bilateral pulmonary infarcts and increasing BUN and creatinine. What medication you are taking?
Heparin.
Do you have any past history of any renal problems?
No, doctor. I was feeling completely normal until recently.
What about your appetite?
It's good.
Any swelling in your feet or ankles?
No, doctor.
Do you have chest pain?
No, doctor.
And your bowel and bladder habits?
Normal.
Any sudden weight loss?
No, doctor.
Your blood pressure level is 130 on 170. There is no organomegaly and no peripheral edema. Your laboratory reports show hemoglobin count 14.8, white count 16.3, sodium level 133, potassium 5.1, chloride 104, and CO2 of 19. BUN test shows 26 and creatinine level is 3.5 and earlier it was 0.9. The CAT scan report of your abdomen shows poor perfusion to your right kidney. I think you have acute renal failure, probably vein thrombosis. Hypercoagulable state is indicated. Deep venous thrombosis with pulmonary embolism. Probably you have developed azotemia due to elevation of blood urea nitrogen, BUN, and serum creatinine levels. Your exposure to intravenous contrast materials may be the primary cause of your condition. I am going to prescribe you rivaroxaban 20 milligrams per day for anticoagulation. Hopefully with this anticoagulation, there will be some relief for your renal vein thrombosis. Or else, if your renal failure becomes progressive, I would advise dialytic intervention. I advise you to undergo a triple renal scintigraphy to investigate the three phases of your renal functioning system. In this diagnosis, a small amount of radioactive substance will be injected into your vein that is taken by the kidneys. This diagnosis involves the use of radioactive substance to investigate your kidneys and assess their function.
Thank you, doctor.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
Now look at question 25. You hear a doctor briefing a colleague about a patient. Now read the question.
Mr. Haskell was admitted last night for chest pain. The initial diagnosis in the A&E was acute coronary syndrome. The patient was given a litre of fluid because his pressure was low. At this point, I started to think the case was peculiar. I thought he had had a heart attack, but he appeared to be a healthy 60-year-old. I realized he was mildly hypoxic and his mediastinum looked enlarged. So I ordered a CAT scan of his chest, looking for a thoracic dissection. This was confirmed when I got a call from the radiologist informing me that the patient had a type 1 dissection.
Question 26. You hear a nurse asking a doctor for help with a patient. Now read the question.
Hello, Dr. Jones. Do you have a minute while I run a situation by you?
Yes, of course. What do you have going on?
I have this patient, Mr. Davis, who is a 91-year-old resident who has been here for several months. So he tells me that he has an ache in his right foot. He thinks he might have stepped on something or twisted his ankle, or he might have got bitten by a bug. I notice that his ankle is reddened, slightly swollen, and warm to the touch. Mr. Davis' temperature is within normal limits, and he has a strong pedal pulse bilaterally. Right now, he seems to be resting comfortably, but he's still experiencing some pain.
I see. It sounds like the first step would be to get an X-ray to rule out fracture. We also need to do a Doppler ultrasound to rule out deep vein thrombosis. That will be even more serious than a fracture, and it also means that we need to act fast.
Question 27. You hear part of a morning briefing in a hospital ward. Now read the question.
Good morning, everyone. We will now go through overnight admission. Jason, could you get us started, please?
Of course. We have Mrs. Perry, who was admitted with complaints of nausea, vomiting, and abdominal pain. Her vital signs on admission were temperature 37.6 degrees Celsius, blood pressure 113/82, pulse 84, and a respiratory rate 20. Initial physical examination revealed distended abdomen, tender on palpitation. Lab results are still pending.
Okay. While we're waiting for lab results, we continue to administer pre-admission medication, and her pain will be managed with IV morphine 4 milligrams every 4 hours. Next, we have
Question 28. You hear a nurse asking a colleague for advice. Now read the question.
Jeannie, I have this patient that I need some help with.
I'm happy to help. Are you referring to Mr. Menendez? I met his wife. She's so nice.
Yes, that's the patient. Mr. Mendez was recently diagnosed with diabetes after presenting in the A&E about a month ago with nausea and vomiting and general confusion. He is overweight and says he does not regularly exercise. He is also not following a special diet and says he eats whatever his wife puts in front of him because it is all so good. Mrs. Menendez reports that her husband has been very thirsty lately and makes very frequent trips to the bathroom. She also said her husband seems to have got worse since his diagnosis.
It sounds like both need to work with a diabetes educator to learn about blood glucose monitoring, medication administration, as well as proper diet and exercise. Diabetes is an overwhelming diagnosis and requires long-term follow-up and support.
Question 29. You hear a podiatrist presenting a course of treatment. Now read the question.
Charles presented with a painful ingrown toenail on the big toe of the right foot that had been going on for about 4 months. As a result of this, he has not been able to wear closed-in shoes. He had 2 courses of antibiotics before coming to my office. Upon examination, I could see that the nail was clearly deep within the side of the toe and causing quite a lot of pain. I considered simply cutting back the nail, but found it was necessary to remove the nail edge under local anesthetic and apply a chemical to prevent regrowth of this section. Then normal daily wound care commenced. The patient reported no discomfort at this point, and the area healed within 4 weeks.
Question 30. You hear a patient asking a physiotherapist about his current treatment. Now read the question.
So, as you already know, I have been experiencing shin pain since I started to increase my training regimen to prepare for a triathlon.
Yes, you've been working with the exercises I gave you for the last 3 months. Have you seen any improvement?
No, in fact now I'm experiencing pain in my shins when I walk, which didn't happen before.
Oh, I see. Since the exercises do not seem to be having any effects, you are experiencing intensified pain. This is something more serious than I originally thought. I'm going to recommend an x-ray to see if there is any bone injury. In the meantime, no exercise at all. We need to keep you off the foot while we figure out what's causing this.
Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Now, look at Extract 1. Extract 1, questions 31 to 36.
You hear the doctor giving a lecture on anticoagulation therapy for patients with endocarditis.
You have 90 seconds to read questions 31 to 36.
Hello, doctor. Can the patients with endocarditis be safely anticoagulated?
Managing anticoagulation in patients with endocarditis needs a personalized approach, using a careful risk-benefit evaluation on a case-by-case basis. There is a lack of high-quality evidence. Therefore, the recommendations also vary according to the clinical condition. Newly diagnosed native valve with endocarditis itself is not an indication of anticoagulation. The question of anticoagulation arises in patients who have a pre-existing or coexisting indication for anticoagulation, such as deep vein thrombosis, atrial fibrillation, pulmonary embolism, or an artificial prosthetic heart valve. The question becomes yet more complex in patients with cerebrovascular complications and a coexistent strong indication for anticoagulation. Earlier studies have suggested a significant risk of cerebral hemorrhage with anticoagulation in patients with native valve endocarditis. Consequently, some experts have expressed skepticism about these findings. Moreover, this skepticism arises from the studies that showed a lower incidence of cerebrovascular complications and smaller vegetation size in patients with prosthetic valve with endocarditis, in which most of the patients received anticoagulation therapy. The mechanism responsible for this effect is considered that the vegetation is an amalgam of destroyed cells, fibrin, and platelets. with anticoagulation preventing the growth and propagation of this aggregation. Some experts are of the view that the incidence of ischemic stroke with hemorrhagic transformation in patients with endocarditis receiving anticoagulation is overestimated. According to this concept, the beneficial effects at least counterbalance the harmful effects of anticoagulation. Moreover, the recent studies have shown that patients on anticoagulation tend to have fewer cerebrovascular complications and smaller vegetations. The studies reveal that not only are the cerebrovascular complications less common in patients who were already on anticoagulation when endocarditis was diagnosed, but also there was no increase in the rate of hemorrhagic lesions. These were all non-randomized studies, and most of the patients had native valve with endocarditis diagnosed at an early stage. Significantly, these studies revealed that there were only beneficial effects of anticoagulation if the patient was receiving Warfarin before the diagnosis of endocarditis and initiation of antibiotic therapy. No benefits from anticoagulation were seen once antimicrobial therapy had begun. Therefore, starting anticoagulation and antiplatelet therapy for the sole purpose of stroke prevention is not advised for the patients with newly diagnosed endocarditis. For most of the patients with endocarditis and stroke or suspected stroke, anticoagulation and antiplatelet therapy should be temporarily discontinued. This is a need of careful evaluation, individualized assessment of the patients and the risk factors predisposing the patients to cerebrovascular complications, such as large vegetations or very mobile vegetations, or causative pathogens, such as Candida spp or S. aureus. Therefore, may prompt temporary suspension of antiplatelet and anticoagulation therapy. In case there is a clear pre-existing or coexisting indication for these agents and surgery is not expected, consider continuing anticoagulant and antiplatelet therapy, providing that patients are free from the risk factors described above and suspicion of stroke has been excluded. In case surgery is considered for the patients with a clear pre-existing or coexisting indication for these agents, then a short-acting anticoagulant, such as intravenous or low molecular weight heparin, can be given as a bridge to surgery. Extract 2. Questions 37 to 42.
You hear a medical podcast on the causes and issues in leukemia patients.
You have 90 seconds to read questions 37 to 42.
Hello, I'm Dr. Gonzalez, and in this podcast, I'm joined by Raman, who is a patient here at the Whittington. Welcome, Raman. Tell me, Raman, tell me something about yourself.
I'm Raman. I'm 14 years old. I used to have leukemia that went on for 4.5 years.
Can you tell me when it was diagnosed?
When I was 8.
So tell me something about what it was like to have had leukemia when you were 8 for 5 years.
Terrible. I felt that I was very strange because when I lost all my hair, some neighbors used to take the mick, and I was harassed in primary school for it, and that was really a bitter experience.
Were you admitted to hospital for a long period?
Yeah,
How long were you in the hospital?
3.5 years.
Fewer healthy white blood cells, platelets, and red blood cells produce the symptoms of leukemia. Based on the speed of growth and the types of cells involved, leukemia is classified into different categories. Moreover, the classification is based on how fast leukemia progresses. You must have had a really terrible time.
Doctor, can you explain to me about leukemia?
Actually, leukemia is cancer of the body's blood forming tissues. That includes the lymphatic system and bone marrow. There are different types of leukemia. Certain forms of leukemia are more common in children. Other types of leukemia affect mostly adults. Usually, leukemia involves the white blood cells. In fact, the white blood cells are powerful fighters of infections, and they normally grow and divide in an orderly manner according to the need of our body. However, in leukemia patients, the bone marrow generates abnormal white blood cells that function improperly. It is really very complex to treat leukemia, depending on the type of leukemia and many other factors. However, there are strategies and resources that can help to make a successful treatment.
What actually causes leukemia to form?
Scientists are yet to identify the cause of leukemia. It appears to develop from a combination of genetic and environmental factors. In general, leukemia occurs when some blood cells get mutated in their DNA, which are the instructions stored inside each cell that guides its action. There may be other alterations in the cells that could contribute to leukemia, which are yet to be identified completely. Certain abnormalities cause the cell to grow and divide more rapidly and gains the ability to live continuously, even when the normal cells would die. Over time, these abnormal cells crowd out healthy blood cells in the bone marrow, resulting in fewer healthy white blood cells, platelets, and red blood cells, producing the symptoms of leukemia. Based on the speed of growth and the types of cells involved, leukemia is classified into different categories. Moreover, the classification is based on how fast leukemia progresses. In acute leukemia, the abnormal blood cells are immature blood cells which cannot function normally, and they have a rapid growth, worsening the disease very quickly. Therefore, acute leukemia requires aggressive, timely treatment. There are many types of chronic leukemias. Certain types of chronic leukemias produce numerous cells, and some produce too few cells. Chronic leukemia targets mature blood cells. These blood cells replicate or accumulate very slowly and can function normally for a certain period of time. Some other types of chronic leukemia produce no early symptoms and become unnoticed or undiagnosed for many years. The second classification is made based on the type of white blood cell affected. Lymphocytic leukemia affects the lymphocytes that form lymphatic tissue that compromises our immune system. Myelogenous leukemia affects the myeloid cells that produce the red blood cells, white blood cells, and platelet producing cells.
Doctor, can you explain to me the risk factors involved in this disease?
Patients who have received certain types of radiation therapy and chemotherapy for other types of cancers have a high risk of developing certain types of leukemia. Genetic abnormalities also seem to play a prominent role in the formation of leukemia. Genetic disorders such as Down syndrome are vulnerable to leukemia. Exposure to certain chemicals, such as benzene used in the chemical industry, is connected with an increased risk of certain types of leukemia. Smoking increases the risk of acute myelogenous leukemia. If any family member has been diagnosed with leukemia, then you have an increased risk of leukemia. However, Most people with such risk factors do not always get leukemia. Moreover, many people with leukemia have none of these risk factors as well.
That is really terrible to know, Doctor.
Yeah, of course.
This is the end of Part C. You now have 2 minutes to check your answers.